Becca. Thank you very much. Okay, so I'm going to start with the land acknowledgement. The University of Manitoba campuses are located on the original lands of the Anishinaabe, Anishinaabe, Dakota, Oyate, Dene, Inuit, and on the national homeland of the Red River Métis. I acknowledge the harms and mistakes of the past and the ongoing harms of the present. I acknowledge the historical oppression of lands, cultures, and the original stewards of this country. I know we have a role to play in challenging the legacies of colonization that we share together. With this understanding, I commit to supporting active reconciliation, meaningful change, and creating of an environment where we recognize our duty to fully provide culturally safe and trauma-informed care. As a physician, I acknowledge the importance of understanding the intergenerational effects of trauma and how it influences my patients and presenting into the emergency department. So the objectives of this specific talk are to talk about our QI project. And for the community members who are attending the rounds, I'm sorry that this is mostly focusing on a smaller QI project that's focusing just at HSC and St. B. And it's focusing on multiple aspects of opiate-related presentations, but Suboxone microdosing is going to be the focus of this presentation. And we'll also talk about how we will refer patients to the RAM clinic as part of the QI project. So what is CRISM? CRISM is, hang on a second, I'm just going to reduce my video. CRISM is the Canadian Research Initiative in Substance Matters, and it is an expert network that has research scientists, policymakers, community leaders, and people with lived experience with substance use disorder, and they are a team who works on translating best practices and influencing policy change. And the primary funder of that is CIHR, Canadian Institutes of Health Research. So we have funding from CIHR via CRISM. And CRISM's focus is to develop community-based treatment, harm reduction, and prevention interventions, research, treatment, and prevention services, and to produce national opiate use disorders is just a small sampling of things that they do. And I just included this map at the bottom to say it's a national organization. Prior to implementing this QI project, the primary researchers, including Andy Kessler and Catherine Dong, they conducted a modified Delphi study to create a 13-item checklist of practices felt to have the highest influences of improving ED care for people who use opioids. So in our QI project, we're going to focus on 4 of the checklist items because some of the items that they listed we already have available. And so our main focus is going to be on education on substance use and harm reduction, a protocol for Suboxone initiation in the emergency department, and we're starting with microdosing, creation of an opioid withdrawal set, and referral pathways to OAT prescribers. So emergency departments, they often serve as critical points of intervention for individuals who are experiencing harms related to opioid use. However, despite an interest and willingness on behalf of many clinicians, EDs tend to lack standardized protocols, resources, and training needed to provide a variety of substance-related interventions, including effective initiation and maintenance of opiate agonist therapy or Suboxone. Concerns have been brought forward that the ED will be inundated with patients requesting Suboxone starts. And this QI project is intended to focus on patients who already come to the emergency department with a separate problem. For example, they came in as a trauma, they came in for a wound check, or some of our bizarre behavior patients after they've been there for a while and you're getting ready to discharge them and you find out, oh, actually, this person uses opiates and they're not in active withdrawal. That is the time we're going to engage them in this kind of project. And so here we've got a CMAJ national survey, again by Kessler, who is one of the primary researchers of the QI project. They did a national survey throughout 22 sites. Manitoba was excluded for some reason, I'm not entirely sure why. And they had almost 650 eligible respondents. And of the physicians who responded, they found that 69% of physicians were willing to prescribe buprenorphine. And of that group, about 25% of them said they ended up prescribing 1 time a month. And so if we take that, there was a total of 447 physicians that 69% of 649 docs makes it 447 docs across 22 sites, divided by 22 sites is about 20 prescriptions per month. And the majority of respondents were from BC, where they have a significantly higher opioid use disorder presenting to the emergency departments. And so just using those numbers, we think we'll probably have fewer than 20 starts per month here in Manitoba. But again, we'll see what happens once we start the project. And so the question always comes up, why should we be doing this in the emergency department? And I'll present my arguments. So Manitoba has a third highest opioid toxicity mortality rate in Canada. And in 2024, there were 371 fatalities due to opioids. And people who die from overdose tend to visit the emergency department 9.6 times more than age-matched controls. And those patients are overrepresented by our Indigenous patients. And our Indigenous patients are 5 times more likely to have an opiate-related event and 5 times more likely to die from an opiate overdose. And this study from the Annals of Emergency Medicine found that in the short term, mortality post-ED discharge from patients who have overdosed, 20% of patients die in the first month, and 22 of those who died within the first 2 days. So opioid agonist therapy, naloxone kits, and harm reduction supplies, it would be a good way to shift as their life-saving interventions. And so people who overdose are at high risk of mortality within 1 year. For comparison, the 1 year mortality post non-fatal MI in the literature is 5.9%, whereas with opiate use disorder, the risk of mortality from overdose is 5%. OAT is associated with improved health outcomes, reduced overdose rates, including for people who continue use. If you start Suboxone and they continue to use opioids, they still have improved outcomes. Opioid agonist therapy reduces illicit opioid use after 60 days compared to motivational interviewing. And for our benefit, in the long run, it actually lowers ED utilization at 6 months. There's another study in 2015 in the JAMA. Suboxone starts in the emergency department, increased retention rates in treatment at 10 weeks. And so they found for patients who were started on Suboxone within the emergency department, 78% of them were still on Suboxone at 10 weeks, compared to 37% who had just a simple referral and 45% in the brief intervention group. And the main reason for that is oftentimes that patients are really ready and motivated. They are at a vulnerable moment. They're looking for help. And as you know, we end up being like a primary care provider for many of the patients because they're not going to GPs. They're using the emergency department, and that's where they're coming for most of their care. So CJAM actually also published a study on patients. Do you want to get Suboxone, and would you be happy if the emergency department offered it? And of the patients who were offered Suboxone in the emergency department, 42% of them accepted. And so not all patients who come to the ED want Suboxone starts. For the most part, they're not interested in coming to the emergency department, and they would rather avoid the ED. And the majority of people don't like the long wait times either. And this other study also found that we are actually a good site for starting Suboxone because the patients who did best on starting Suboxone are those who had never been on Suboxone before, or those who had been using for less than 10 years. In BC, they'll have people who are quite entrenched with their opiate use disorder, and they're using very high doses. And so they didn't do as well on Suboxone. A qualitative study, emergency department patients with opioid use disorder just took some comments from patients that I thought was interesting. And one comment was that people are willing in that moment to get Suboxone in their hands right then. It's a good thing to get it in their hands. They're very vulnerable and they're open to it. And I'll say when I've started Suboxone in the emergency department, and I've seen a lot of the patients actually, if I look at their DPIN and I see that they're followed by a community provider who prescribed it to them before and maybe they stopped. So I knew that they would have somebody to follow up, or they were from an access center. Many of those physicians would find me on Tiger Connect and thank me for starting Suboxone, saying you found the person, they were in withdrawal, they really wanted to, they were having a hard time connecting with me. And some of them will send me updates every 6 months or a year later to say they're still on Suboxone, they're still on Suboxone. So the physicians in the community also appreciate that we're taking the chance to start them for those who are presenting in withdrawal, which is a bit of a side because that's not really what we're focusing on today, but I thought it was a nice anecdote. So going on to the QI project itself, our mission statement is pretty simple: to increase the number of patients being provided appropriate opiate use disorder interventions, improving opiate use disorder identification, therapeutic options, and connection to follow-up. And our SMART aims are for patients who present to St. B or HSC with opioid use disorder. We aim to offer Suboxone prescriptions in 70% of those patients, with an uptake of 40% of those who are offered, with 70% of those who receive the blister packs to attend their follow-up. And we have funding until July of this year. Our SMART aims are to increase the number of patients receiving harm reduction supplies by 40%, to increase the number of patients receiving Suboxone kits in the ED from 0 to 5, to increase prescribers at HSC by 20%. I didn't put St. B's in there yet because I have to get more data. Increase the number of monthly Narcan kits dispensed on a median from 7 to 12, and offer education to nurses, social workers, and community outreach workers, with 80% of the staff completing post-educational surveys. So what is buprenorphine, just briefly, because I think we have had rounds on this before. It is a form of opiate agonist therapy. It's considered first-line treatment for opiate use disorder, and it's an underprescribed life-saving intervention. It's a combination of two different medications: buprenorphine, which is a synthetic partial opioid agonist, and naloxone, which is an opioid antagonist, and it's included in the formulation to prevent injection and diversion. And so naloxone itself has poor sublingual bioavailability, and when taken properly, the naloxone will not have any impact on the buprenorphine. And with the buprenorphine itself being a partial agonist, it prevents withdrawal, it has less cravings, there's no euphoria, and there's significantly less sedation compared to the illicit opioids that people are using. It comes in a 1-to-4 ratio of buprenorphine to naloxone. For example, 2 milligrams buprenorphine to 0.5 naloxone, or 8 and 2 milligram tabs, and they can be cut into different dosages. So in our blister pack, we'll be starting with 0.5 milligrams sublingually BID, and so the tablet will actually be cut by our pharmacy or by Northway Pharmacy into 1/4 tab to start. The pharmacology of buprenorphine: it has a high affinity and slow dissociation, binds very strongly to the mu opioid receptors, and it dissociates slowly, giving approximately 24 hours of effect. It has a higher affinity for the mu opioid receptor compared to other prescribed and illicit opioids, meaning it will block the blue receptor and the mu receptor, and will also have some protection against overdose. It is a partial opioid agonist. It'll provide enough activity to prevent withdrawal symptoms and cravings with less sedation. And the ceiling effect is actually also incredibly beneficial in that going beyond doses of 24 to 32 milligrams, which is the maximum typical dosing for Suboxone, it reduces the risk of respiratory depression and side effects, lower risk of QT prolongation, and lower risk of overdose, especially if they're combining with alcohol and benzos. So if you take enough over alcohol, significant amounts of benzo, significant amount of fentanyl while you're on Suboxone, you can still overdose. But if they're using lower amounts, or as the Suboxone dose increases over the 4 or 5 days when they first start it, they will reduce their illicit opioid use because they will not have the cravings and they will not be going into withdrawal. What are the contraindications? Allergies, severe liver dysfunction, paralytic ileus, if they're already on methadone or Cadian, and we don't see a lot of Cadian here, or if they are getting prescribed opioids or they're just not interested. What are the side effects? They're quite mild compared to other using opioids in general. So you can get precipitated withdrawal, meaning if you're doing a standardized dose of Suboxone, which is much higher, let's say 4 or 8 milligrams start, and they've recently used opioids, the Suboxone will preferentially bind the mu receptor and bump off the opioids that are on there. And since it's a partial agonist, they'll go into significant withdrawal. And Yeah, that you can actually treat very easily with giving more Suboxone. They can experience sedation, headache, nausea, vomiting, constipation, hyperhidrosis, which you can treat with clonidine, vasodilation, and sexual dysfunction. We do find that chronic opioid use in general will lead to low testosterone levels and sexual dysfunction in men. So it's not specific to Suboxone. The inclusion criteria are a diagnosis of opiate use disorder or evidence of opiate use disorder. They cannot be in active withdrawal for microdosing, meaning the COWS or the clinical opiate withdrawal scale should be less than 8, or they should not have used any opiates less than 12 hours since they want to be recent use. So less than 12 hours from short-acting opioids like hydromorph or morphine, or so they should have used less than 48 hours from fentanyl or down. And if they say they used fentanyl, it's not typically our short-acting fentanyl that we're using in the emergency department. More often than not, it's a more longer-acting form that they mix in down because they don't know for sure what's actually in the down that they're using. We have to ensure that they have medication coverage, that they're covered either by EIA, NIHB, private insurance, or if they have the ability to pay, and it's about $25 a day. They have to be willing to attend a pharmacy for daily witnessed ingestion, and they have to be willing to follow up at around. So exclusions are allergies, severe liver dysfunction, paralytic ileus, opioids, and they're not interested, or if they're in severe withdrawal. The clinical opiate withdrawal scale is actually it's very easy to use. It's similar to what we're using for CWA already. And then we don't need to go into all of this in detail, but some of the things that are more specific for opiate withdrawal is goose flesh, if they have piloerection, and we examine their pupils if they have mydriasis, and we can easily score them using this scale. And so far, I found the rare time that I've used it, sometimes I just go online and I print it off. And I've asked some of the nurses to help me. It's been pretty straightforward and easy to use. Here's a draft form of the opiate use disorder set that we've been working on, and Amy Clausen at St. B has been fabulous in helping us make this. And so there are still some edits going on, but it's basically going to be pretty straightforward with a bunch of tick boxes for the physicians to use. So the inclusion criteria is on there, the exclusion criteria is on there. You'll just have to basically tick off a few things for giving the patient the first dose of Suboxone, which is the 0.5 milligram of buprenorphine, 1/4 tablet under the tongue. When it goes under the tongue, it has to stay under the tongue for 2, 3, 4 minutes until it fully dissolves. So a patient can take a drink of water, their mouth can get wet, but when it sits under their tongue, we don't want them eating or talking or drinking a lot of water until that Suboxone is fully dissolved. And then after they've taken the first dose from the blister pack, we actually give them the remaining pills from the blister pack, which is going to be a total of 5 days of medications. And then they take that with them. And so basically what it's going to be is 0.5 milligrams BID for the first day, 1 milligram PO BID for day 2, 2 milligrams PO BID for day 3, then 4 milligrams PO BID for day 4 and 5. And then we will aim to get them an appointment at the RAM clinic within the first 5 days. So the RAM clinic is going to be holding, I'll show you this. The RAM clinic is going to be holding 6 appointments per week for HSC in St. Boniface. So Health Science Center will get Monday, Wednesday, and Friday at 12:30. And St. Boniface will get Tuesday, Thursday, Saturdays at 12:30. And we're going to have a little book similar to the orthopedic MSK clinic referral book at HSC, where you just open up the book, you find the appointment dates, you write the patient name in, and then that'll signal to others that that appointment slot is taken. And then we will also have an appointment slip that is going to be similar to our orthopedic surgery, our MSK referral form. So you can just write in the form. You were assessed by Caroline Kowal on January 20th. You're being referred to the RAM clinic. And we want the date for them to go to the RAM clinic would be better, not the very next day, but probably towards the 4th or 5th day when their blister pack is about to end, so that the RAM clinic can reassess their dose and increase the dose and take over. And so once you have given the blister pack, you have the appointment chosen time from the book, you fill out the appointment slip, Then on the order set, it's actually going to remind you that you also need to write a consult note for the RAM clinic. And then the unit clerk is going to fax the ED visit summary, the consult, and the appointment slip to RAM. And then we would give the patient the appointment slip. And we're also going to give them a little handout on the buprenorphine Suboxone blistering pack that is going to explain to them how they use it. And we'll just give them the regular RAM referral form. And we'll have all of that sort of punched together in a little package. So you will have a package of things that you can, information and paper you can give to the patient, as well as the blister pack. And I put this in here as a side note just to show what they're doing in Vancouver. For example, for take-home initiation, they're not using the blister packs because they're more expensive for them. Like our pharmacies here were willing to negotiate a nice price to assist us with purchasing of the Suboxone blister packs. So they're using a separate vials, and they're giving people 2 milligram tablets, and they give them 24 tablets of the 2 milligrams, and the patient themselves is taking 2 milligrams Q1H up until the time when they no longer feel that they're in withdrawal. So they get 8 tabs to a maximum of 16 for day 1. And then day 2, they're getting additional 16 tabs up to a total of 32 milligrams, and the same with day 3. So they're dispensing 48 milligrams or 24 tablets. And so I know that there was some fear about Suboxone being unsafe in the community and putting people at risk, but generally speaking, Suboxone is felt to be quite safe because it prevents them from overdosing. And if they do take too much, they're going to get sedated. They do not experience respiratory depression. And then Zoe put a comment up on, hang on a second. I'll get to that in a minute if that's okay, Zoe, unless you want to.
Sorry, Carolyn, just a quick question about the consult note required for RAM.
Yeah.
Does it have to be a specific consult form, or can we simply ask our unit assistants to print off our ED assessment, like our assessment and summary note with the plan, and send that with the required paperwork? Is that all they need?
That's what we're doing. Like at St. B, when you consult cardiology, do you write a consult in the emergency note?
It depends, like depending on who you're consulting, sometimes an electronic order entry is required, and sometimes a specific paper form is required, like for CIVP, for example, there's like an order set and you just tick it off on paper. And then when the unit assistant sends that paperwork to CIVP, they also print off and send the ED assessment note so that the history is available there for the consultant.
Yeah, I guess we'll have to figure out the best way to do it at St. B, because at HSC, we have to type out a consult for every consultant who we consult. And so if we're referring to the early pregnancy assessment clinic or to the MSK clinic, we often write a little consult, and that goes with our outpatient referrals. And so
okay, I'll have to clarify
whatever, yeah, if we can do, the RAM clinic has been very flexible with working with us, and maybe we could follow up on that after and figure out the best way to do it. But whatever works best for you guys and is already kind of in line with what you're doing, I'm sure we'll be fine.
Sorry to interrupt, but I think also the issue too, in terms of having a formal consult paper trail, is for billing for certain consultants. So it's not just a matter of communication, but I think they also need the consult.
Yeah.
But I'm not sure if that's the case with RAM. So
Yeah, we'll follow up on that from the St. B side of things. Good question. As part of the funding, we will have some funding for gift cards for the nurses and social workers and SEDVIP workers for when they've completed their education. And then also, we're going to start a competition between HSC and St. B to see who can dispense the most Narcan kits, the highest number of nurses who are educated, and the highest number of Suboxone blister packs. So stay tuned. You may see some poster boards coming up in your departments, and we'll just update the numbers as the time goes on to see. And then the winners it'll be food related prizes. So a bigger food related prize to the team who distributes the most, and a slightly smaller food related prize to the second place hospital. And Just as a reminder, every time we are sending people home with a blister pack, please give them a Narcan kit and give them harm reduction supplies. And even if they say they're not injecting, Street Connections encourages people to take harm reduction supplies with them because they're often using with other people who need harm reduction supplies. It's considered a secondary form of distribution. And so at HSC, our Narcan kits and harm reduction supplies are located in the cubbies behind the CRN desk underneath the water fountain. And I think at St. B, your Narcan kits are just in your order set in your Pyxis. So if you order it, they will come. And that's automatically included in the order set that we're creating for this project. And for those of you who don't know what's in the harm reduction supply baggie, there are alcohol swabs, a tourniquet, some syringes, and some cookers. And the cookers they just use to heat up if they're dissolving any products instead of using a spoon. That's pretty much it. And it's in a nice small bag that should be easy for them to carry around. And it's dark, so people don't know what they have in there. That's pretty much it. Questions? Oh,
Caroline, can I,
sure.
can I start us off?
Yeah.
Hey, it's Tom. Thanks for all the hard work you've done on this and the Narcan kits. I know this was a tough thing to work through, so kudos to you guys and Shane and Devon. My one question to you guys is your exclusion criteria kind of alluded to people with short-acting opioid use, non-active withdrawal. And I just find these patients sometimes are a little bit tough to peg down in terms of their history of usage or whatnot. How strict are the exclusion criteria related to their opioid use or what they've used? Wonder if you could speak more to a bit about that and how you approach the patients where the history might not be totally clear.
That's an excellent question. The criteria is very loose. If they're not in withdrawal, they qualify. And so the order set does include some adjunctive treatments on the side. So we included things like clonidine, Gravol, ondansetron, loperamide in case they're experiencing withdrawal. And if the patient is in mild withdrawal and they're really insistent, like I don't want to do a standard start. I want to get out of here. I want to leave. I'm going to go out and use. That's okay to give them the microdosing, just knowing microdosing will not treat withdrawal in any way because you're starting off with such a baby dose. So the idea is they are continuing to use. And so if they used recently and they feel good and they're not in withdrawal, they qualify. And then they'll start their microdosing. And then by about day 4 is when their mu receptors are going to be more saturated because at that point they'll be on 4 milligrams BID. They should really be cutting down their illicit opiate use and be feeling quite a bit better already. And then we should get them into RAM by about day 5, 6. Did that answer the question?
Maybe I'll just ask my question. Tom's question was partially one of the ones I had, so that's great. Great work on getting this up and running, and for sure you will recognize this is the culmination of about 5 or 6 years of failed attempts before. And obviously RAM as being a partner is a big part of this. One question and a comment or two, just in terms of, we've got some funding for it sounds like a pretty short period of time. Is the thought then that when that ends, that we'll just cook this into our normal kind of work processes in some other way? Or any thoughts about, like, I'm assuming we'll want to keep doing this after that funding ends. So just one kind of question about that. And then the second one was just around just some of that documentation. I'd maybe put in a plug once you get it all in sort of like production state. Feel free to send it to myself or Muzine, and we'll put it up on that website so that you can just basically download it and print it while you're on shift. And we'll just create another section on there if we don't already have something. So thanks. Looks great. Hopefully we can get some processes that contribute to some benefit. And then I think we probably also could give out more Narcan kits because I don't think we give out quite enough. I think if we were to look at our Pyxis use, it's pretty low. And I think it's kind of fallen a little bit out of our work process. So I think that's great that you're offering some competition for that because I think we underutilize that.
Yeah, competition, and it will be ingrained in the order set so that it's just a tick box, or it should actually be shaded in so that every single time you give somebody Suboxone, it's on automatic. So going to funding, that was one of the requirements actually of the CRISM study that they wouldn't give us funding to purchase Suboxone blister packs unless we had a downstream plan for continuation. And so fortunately, we've actually had some really great support from Zoe, Chow, and Travis and the various executives at the two departments to continue funding and roll it into our budgets. So the plan is that it will continue beyond July.
Just out of regular operating funds. Great.
Regulating, yeah. And Northway Pharmacy has been really great also at offering like I think it's maybe $19 for the blister pack and all the meds for 5 days.
Yeah, that's great. Long overdue. Those papers were published in 2015.
Correct. Chow. Well, Chow, did you want to go next? I see Chow and Zoe have their hands up.
I'm guessing that Chow might be frozen. Her image is not
Yeah.
moving.
I just that just occurred to me. Yeah.
Maybe I'll go. Oh, here she is again.
Sorry, I got frozen. But go ahead, Zoe.
My question was just about patients who are not great candidates for microdosing because they are in active withdrawal, and that it's not really covered by this pilot as it exists now, but there may still be people who want to do this but are sort of still newbies in terms of especially macrodosing Suboxone. Would you recommend that during this phase anyway, we just seek help from the on-call addictions physician if somebody wants to do some kind of Suboxone start for someone who is in obvious withdrawal in the emergency department and they need a bit of advice?
Yeah, these are all fabulous questions. So yes, if a person's in withdrawal and they want to start Suboxone and you are a Suboxone prescriber, awesome. If you're not a Suboxone prescriber, all you have to do is just write the college an email saying that you would like to become a Suboxone prescriber and they will give it to you. And that you are not required to do the 2-day course that they previously suggested. And if you have attended this grand rounds and you're following the order set, that's sufficient. Devon and I also have separate ERP primers if you want to read. That would be pretty quick to become familiar with Suboxone use. And so, and the long-term goal will definitely be to make order sets for standard induction and macro dosing options for us. So in the meantime, yes, if you want to start and you need some help, you can text me. I'm happy to help. I'm sure Devon would be happy to help. And you could also, it's the RAM physician, the 24/7 on-call doc. I think they are pretty strained with their resources. I know, of course, there's been a lot of chat at HSC, like we really want them to come and see the patient and do the consult. And that happens infrequently. And I think it's because they are stretched resource-wise. So they're pretty happy to help over the phone. They just wanted me to make sure that everybody knows it's not necessarily the AU doc on call. RAM has their own separate 24/7 physician who's on call, who I have phoned. Like I started somebody on Suboxone recently who was in withdrawal while on Sublocade, and that person helped me over the phone. The other thing we're going to do is have pre-made, very simple prescription templates that will make it really easy to prescribe Suboxone eventually, because you have to have it written out properly for the pharmacy to dispense it. Ciao.
I just wanted to give kudos to both Carolyn and Devon for all of their hard work and effort. As Paul mentioned, this has been a very hot topic at a lot of decision-making tables, including the lower wait times group. And the biggest limiting rate for us was really ensuring that we had long-term horizontal collaboration with RAM so that our patients who are starting the ED get that longitudinal care. And we're really excited that this was tied with a research project, because more importantly, the data points will help us to reinsure the sustainability of the implementation, because there's no doubt that if this is going to be beneficial, which I have no doubt it will be. We have a large cohort of vulnerable patients at both HSC and St. B, as well as throughout the entire province. And starting with the 2 sites will be a great initiative to roll things out later in the urgent cares and the other ED as well. But at least the data points will help point us on the right path, that this is going to be sustainable and that the funding is supported by AED leadership, at least from HSE site. And I know the Zoe has also supported that as well too, from the St. B site. One of the things that I just wanted to mention, and I'm not sure if I heard that, is part of the order set is that the physician who's completing the order set needs to have a Suboxone license to complete that. So I'm hoping that after this grand rounds, that anybody who doesn't have their license is wanting to be a part of this innovative pilot project will get their license. It's not hard. So at least we can get the data points that we need to give our patient population the care that they need and the follow-up that they need.
Thank you, Chow. That reminded me that the lower wait times table, I think there's been some work trying to find more primary care providers who would be willing to take on patients who are started on Suboxone. And so what Erin Knight will do at RAM is that she'll accept our patients, she'll stabilize them, and once they're stabilized on a dose of Suboxone, the RAM will also help connect these patients with primary care providers who will continue their Suboxone. So it's going to be more than just referring to RAM. On RAM's end, they're going to connect them to primary care providers. Oh, and thank you, Devon. You just emailed Talia Carter at cpsm.mb.ca for your Suboxone license. Any other questions? One thing I see, Linda, thank you. I'm great. That's great. Linda, thanks for attending. Just so everyone knows, HSC has done some work like from the executive level on distributing harm reduction supplies. And there's now a hospital-wide policy that any staff member, if they're approached by a patient and they ask for a Narcan kit, or if they are asked for harm reduction supplies, they can be dispensed. So if a unit clerk is approached, if the greeter at the front door is approached, if a nurse is approached, it doesn't matter. If a security guard, I guess, in theory, according to this policy, is approached requesting, anyone can hand these items out.
Okay, that's good to know. We actually did have a bit of a situation the other day where a nurse in triage just couldn't find it. And so, we got it, made sure it was restocked, and it is apparently going to be restocked regularly, right, through supplies, which is fabulous. I So I just had one little thought. Maybe this is kind of premature, but I thought when this gets off the ground and is rolling, I think to just really ensure that we're successful with our patient population, would be discussing at some point the role of social work in connecting with the community teams of our more vulnerable patients, right? Because we know they're most successful when their team is available and follows up and makes sure they gets to appointments, or right. So, but we can talk about that further down the road. I just wanted to kind of throw that out there as a piece that we might be able to do, right, to ensure the adherence.
Yeah, we want to make sure they can actually get to their appointments. I don't know
That's
if
right.
Zoe Oliver is on this. I know SEDVIP has recently received some more funding for the SEDVIP workers to target youth who are
Overdose.
overdosing.
Yep.
Yeah, and then helping them get to, Tammy from SEDVIP. I don't know if Tammy, if you know about this additional funding, but SEDVIP has a role to play and to assist with specific patient population and getting them to their follow-up appointment, which is fabulous.
Right.
Hi.
Yeah, that'll be wonderful.
Hi, this is Tammy. Can you hear me?
You can.
Hi, I'm trying to figure out my camera, but I don't know. For some reason, I can't get my camera on, but as long as you can hear me. Yeah, so we've gotten an expansion to respond to overdose to patients that have overdosed and are presenting at HSC and have required medical intervention. We haven't quite landed on how we're putting that into practice yet. So we're just at the very beginning stages of booking interviews for people and interviewing staff. So we'll have an additional 4 outreach workers and an additional 1.6 social workers. So we're working on building the team and doing some training. And then in the midst of it, Shannon Watson, our manager, and I and our social work team, we are having meetings to kind of really land on how we're going to be responding, who we're going to be responding to, so that it's manageable with the expansion, but also so that it's meaningful and it's helpful and it has impact. So we've been in different conversations with Dr. Liz Doyle and Dr. Zoe Oliver, and we have another meeting with them booked at the beginning of February. We're hoping that our expansion is going to be in place rolling by April, and that requires a lot of different steps. So for the hospital to be aware of what they're calling us for referrals, what that expanded eligibility criteria looks like, who that includes, our team all up to speed and trained and ready to be taking the additional referrals from HSC and also the capacity to work in the community. So it's really exciting, and we're still in the building phase, but stay tuned for more information because we're close. We're so close. So I don't know if that was helpful or not, but that's the process that we're in right now.
Thank you.
Thank you.
Well, if there are no additional questions, thank you to everyone for coming and for the multidisciplinary teams who have come. That's great. And then we'll see how this QI project goes and if there's room for expanding to other sites, but we're just starting smaller for now. See how it works.
Thank you so much for a fantastic presentation, and to all of you for the incredible amount of work and effort that's gone into this. It's fantastic. I'm just putting the link again in the chat to the evaluation for today's rounds for both speakers. If you can take a moment to just click on it now, that's very appreciated. The second presentation today has been recorded and will get sent out as well. So thank you again for joining us today. Thank you to our speakers, and we'll see you at the next rounds. Take care, everyone.